Today's session, I'm going to be presenting about functional neurological disorder. We'll try and bring a new perspective to this old malaise. What you see here is from 900 BC, a papyrus from that time. And there are two very important papyri, one of which is the Kahun papyrus, and the other is Ebert papyrus. So one is named after the place, and the other is named by the person where it was found and who found it. The first one, the Kahun papyrus, describes the first historic disorders. It speaks about female patients who do not leave their beds, who have sight disorders, neck pain, pain in the jaw and teeth, who have pain in the arms and legs, extremities, and thus the symptoms are somehow associated with the hunger of the cervix or the upward movement thereof. And Hippocrates has used for this condition the term hysterion, which means the uterus in Greek. Thus, the uterus dries up and moves inside the body, seeking for moisture. And Plato, in his Timaeus, which is a dialogue, which consists of dialogues which he wrote up to his death, she talks about women, saying that the animal inside wishes to give birth and is angry and displeased. It stops their breathing, leads them to extremes, and causes all types of diseases. So we see theories about the uterus in writings dating even back to the ancient Egyptians, but this moving about of uterus within the body is an explanation brought by ancient Greek physicians, it seems. And in the Bible, the book of Luke, here's a chapter which reads, and some people were bringing a person who is paralyzed to bring him before Jesus. And they couldn't do that because of the crowd. And with his bed, they lifted him up and brought him down over the rooftop. And Jesus says, I tell you, get up, take your bed with you, and go. And then, with these words, the man raised to his feet and took away his bed and left for his home. And Galen came up with the term hystericia pinix, and which comes with symptoms ranging from madness to loss of voice, which could end up in death. And if you want to appease the uterus, if you don't want it to move about within the body, he says you need to tame it, you need to calm it down. All these aromatic therapies, massage therapies, and in order to draw the uterus back to its place, lead or stem from this understanding. Hysteria in the Middle Ages most likely seems to be impacted by ideas put forth by Galenus, and you see on the left-hand side Avicenna, the great Eastern physician from Persia, And on the right-hand side is Ibn Maymun, who is from Andalusia, a Jewish philosopher and physician. Both of these persons have written their works mostly in Arabic, or to be more exact, Judeo-Arabic. So both Avicenna and Maimonides. And they for the most time, they stuck with the genital explaining, the uterus being going about in the city, requiring taming in a sense, or appeasement. As we move on to the 15th century, I will be talking about a few European physicians, especially from from England. Thomas Willis has not placed a central role on the uterus and associated the disease or the disorder with the brain and the nervous system. So I was talking about the Islamic or the Eastern view as well. So it was somehow connected with possession as well. So these patients were either burned at the stake or exposed to exorcisms. Thomas Sydenham from the 15th century once again seems to swing back and forth between explanations on the psychological and somatic side, and finds that the uterus is not the main cause and considers it can be comparable, the disease can be comparable with hypochondriasis. And he is also considered as a revolutionary figure due to stepping against or standing against previous understandings. And as we move towards the 17th century, or the 19th century, it is considered to be a nervous disorder. Todd, whom we remember from Todd's paralysis, describes a patient who carries about a paralyzed leg like a lifeless object. Let me try and illustrate. The foot sweeping about on the ground. And this later on is going to be accepted as one of the positive symptoms, dragging the leg. So the first description was made both by Todd, as you see. And in 1859, Paul Brickett, in his monogram, or which could be considered as the first case control study in psychiatry, which was a turning point for hysteria, and demonstrates the connections between sexual abuse and hysteric symptoms. So he follows up more than 430 patients for more than 10 years. And the main, according to Briquet, the main features of this disease is chronicity and pain. And as you would remember, this definition of Briquet would be later on, Samuel Gize et al. Are going to describe this as the Briquet syndrome. And the somatization disorders under DSMs was first made during that time. And this is a painting by André Bruyé from St. Peter's Hospital, depicting a demonstration by Charcot examining a patient in front of a large crowd, wherein he brings about hysteric symptoms in the patient through inducement. And this seems to be one of the most important, most famous paintings in medicine. The patient is Blanche Whiteman, who is known as the Queen of Hysteria. Of course, this is not something that can be accepted in our day and time, somehow forcing people to display their symptoms in front of a crowd. Therefore, some of his contemporaries have called such displays as charcuterie, the shop of charcoal, as a criticism. Then let's talk about charcoal and the modern concepts which we are dealing with today. To diagnose, Charcot says we have to exclude other neurologic disorders and diseases. According to Charcot, functional neurological disorders or conversion disorders should require this exclusion. It is an exclusionary setting, and according to him, there needs to be loss of senses or hypersensitivity, such as deafness, narrowing in the field of vision, oversensitivity near the ovaries, and grand hysteria, which are these hysteric episodes that as we call them today. Charcot talks about functional neurosis. And since pathologies like conversion disorders or migraine is not displayed, he thinks that such neuroses are functional. In hysteria, there are there cannot be any lesions that can be seen in the brain. And according to Freud, Charcot has returned return to this disease its name in a sense. And then Boyer and Freud, in their works, we see that the sexual etiology was returned to. So starting from 1600s, hysteria is considered as a neurological or brain-related disease. But Freud says since unacceptable sexual urges would cause depression, these would be suppressed in order to avoid depression and then cause physical symptoms. And a psychological excitation is translated into completely psychological stimulation is converted into a somatic innervation. And he finds that, I looked at the original German version, and the innervation is the term that was used, which is not used in the sense it has today, I believe. So he finds this to be hard to understand, this somatic innervation being caused by a mental process. It's difficult to grasp concept. And hysteria attacks are found by him as a motorization, so to speak, of fantasies and a miming of such fantasies, and enables a partial satisfaction of the urges in the psychological cells. And when we talk about hysterical conversion right now, we don't have the same symptoms that we have. He talks about certain types of pain, neuralgia, strokes, and many things. So Freud and Breuer have named these or discussed these, addressed these as historic symptoms in their writings, in their studies. According to Freud, since trauma brings about the reenactment of sexual abuse during childhood, it causes disability. So it means that an, a, an abuse that is experienced during adulthood can remind the patient of a previous abuse in childhood, causing disability. And Freud, with his theory of infantile sexuality, has done away with this understanding. Some people think that he really does believe it. Some people say he had to give it up somehow. Therefore, mistreatment during childhood is not a must. But if the patient believes, if the patient fantasizes, with a PH, of course, fantasizes about these things, then it can be brought about. And the analytic literature after Freud really puts a great weight on such abuse. And Freud's model has transformed this understanding of the disease into a solely psychiatric understanding. And all analytic psychiatrists following Freud do not agree with the sexual theory. Fairbairn, one of the third way psychiatrists, if you know, says that conversion is caused by a or replaced by a somatic condition instead of a consciousness related situation. So this conversion helps people to avoid or overlook their problems. Another contemporary of Freud is Piaget, and for neurocognitive scientists, Piaget and dissociation theories are much more likable. And he focuses more on mechanisms instead of tendencies. So instead of looking at the causes, he looks at the mechanisms. And he says that dissociation is a mechanism of the coming up of feelings. And due to some somatic weakness, the normal consciousness synthesis of experiences cannot be continued, and senses and actions leave the consciousness or the awareness of the patient. So there's this dissociation happening. Janet talks about another concept called the hysterical stigmata. And when we talk about stigmata, if I'm not mistaken, it is coming from Greek, and then moves on to Latin. And stigma means branding. Stigmata is the plural for that. And the absence of a objective disorder is most of the time accompanied by indifference, which is a queer subjective symptom. So this was mentioned first of all by Labelle and de France, was used by Freud. And what is meant here is that even though the patients may have very significant somatic symptoms, they don't care for that. And in the analytic literature, this is tried to be explained that with these symptoms, since with the symptoms the patient does away with the depression, it seems that the patient does not care for them. I'm trying to flip through the slides. It seems I've moved a bit too far. So we are going back right now. And John Stone carried out a systematic review. And this label indifference symptom is, or the finding on label indifference is not trustworthy in a sense. So you can see the organic disease symptoms and conversion symptoms as you see on the graph. And for those with an organic disease, label indifference can be observed. So it is not a measure for that. So, why has label indifference continued to be placed in textbooks in our area? So, there is this romantic connection between Charcot and Freud and other historic famous names. And also, maybe just giving a name that can be easily remembered in French increases the value of this clinical symptom. Thus, the with the symptom or with this indifference, I mean, yeah, it can be understood, but it is one of the untested symptoms of hysteria. And even though it has an attractive name, catchy name, it should not be considered as a clinical symptom or finding. And as the discussions around this issue continued during the First World War, the Great War, the returning soldiers were found with shell shock. So, what we mean with shell shock, I mean, yeah, some of the symptoms of shell shock can be considered to fall in line with the symptoms of PTSD, but there are hundreds or thousands of soldiers that returned from the fronts who showed symptoms of hysteria. So it means that the patients are not only women, and sexual trauma or libidinal disorders are not the main cause. And discussions around mingling were also exacerbated because these soldiers, I mean, some of them were trying to get away from the war or trying to get some compensation. So there were discussions about whether it was indeed a real disorder or not. And let's discuss the reasons why neurology and psychology went away from hysteria or conversion disorder. So, studies on hysteria, which was published by 1895 by Breyer and Freud, the brain sciences divided into multiple disciplines. Psychiatry and neurology completely fell apart, and psychoanalysis as a new area came to the fore. So those who cured the mind and those who cured the brain somehow got separated. And with the impact of Freud, as you know, Freud in the first half of 20th century was a very important name and considers hysteria as a psychiatric disorder, which helped neurology to get away, in a sense, from hysteria. Let's look at the reasons on the side of psychiatry. So, the theoretical innovations brought about by Freud were not widely accepted by psychiatrists. So, in North America and in England, in the United Kingdom, such innovations were not accepted by psychiatrists, and the the psychiatry went for a descriptive nosology understanding. This had, we can say that it's had an contribution here in the theoretical sense. And there were also counter-transference related issues. Most of the treatment was based on verbal interaction, but we are talking about mostly physical symptoms. There are episodes that are happening at odd times and they cannot follow up or meet their appointment times. Therefore, psychiatrists or psychoanalytic psychotherapists do not very much like to see these patients, in a sense. And the the leading psychiatric understanding was found to be insufficient or inappropriate to address such patients. And I'm sure you know about Slater. So Back in 1965, he found that this is a English neurologist as well, and patients who were 33% of patients who were diagnosed with hysteria were diagnosed with another disease within the following 10 years, which explains the symptoms at the beginning. So this is the most important observation or claim that Slater had. And he says certain personality features, characteristics bring about a willingness to be diagnosed with hysteria, attention-seeking behavior, and label indifference. All of these personality features, characteristics, somehow lead the physician to come up with a diagnosis of history. And those with a histrionic trait, it means that the loss of power would be demonstrated in a way that is temperament. If it would be shown in a very personal manner. The patient says that they want to be diagnosed with hysteria in a hysterodiagnostic manner. So this paper put forth by Slater was quite important and impactful in the European psychiatry environment, and it caused the. And he continues. History is not just a delusion, but also an entrapment, a snare. And diagnosing hysteria is ignorance in a different cloth. But after 1970, following this claim by Slater, the misdiagnosis rate was found to be ranging from 0.4 to 4%. So it's not like one-third of the patients, as Slater has claimed, would not be diagnosed with severe neurologic disorders such as multiple sclerosis and so on. And there was also an illusion, in a sense, that hysteria has disappeared from the face of the earth. And this can be caused by less symptoms of conversion and people becoming more informed, and with the societies becoming more accepting of sexuality, and history is no longer needed as an explanation. The French psychiatrist, psychoanalyst, and historian Etienne Tria, in his book The History of Hysteria, says that history is dead, that is for sure. And he says, what is left of hysteria right now? Hysteria is for sure dead, and its secrets are buried in the grave with it. And hysteria is a intermediary for perversion, stigmata, and assumptions on society or personality. So we should ask the question whether history has disappeared. So as I was adding the videos, all the typefaces have changed and so on. So sorry about that. I see some of the typefaces have changed. But anyways, let me say, the patient or the disease has not disappeared. They are now counted within a large group, with symptoms which cannot be explained through organic diseases or partially explained, and they are overlooked due to not being diagnosed properly. And the result of this loss of interest in conversion disorder was that since neurologists were unable to come up with neuropathologic explanations for psychiatrists, and the patients were returned back to psychiatrists, and psychiatrists sent back the patients to neurologists due to not being able to find their own diagnoses.
Görüyoruz.
We see that it's changing in the last 5-10 years. There is more interest and there are efforts to find a common language. There are some factors affecting it. First off, psychotic symptoms or anxiety attacks. Epidemiological efforts are not easy for hysteria. So, after giving training to college students and letting them visit people at their door and try to find the prevalence. However, you need to know how to examine people to identify the actually signs of hysteria. So the patients who come to the neurology clinic are evaluated in terms of psychosis. So in 14% of that, there is no objective evidence found. And then later, nearly 30% of the patients' functional neurologic findings are found according to these trials. 10 or 15 years ago in the UK, between the neurologists, there was a survey, and neurologists stated that they didn't use the psychological model for conversion. So they thought that an extra mind work can have a role in it. And for some, conversion, most of the British scientists say that it cannot be differentiated from simulation. Some thought that it is me- it's Mellinger. The signs of conversion cannot be differentiated from malingering. So shell shock or compensation neurosis, these are also political definitions. Well, deceiving is an extensive human behavior. It's seen in animals as well. It relates to their survival strategy. The exact method is the confession by the person. So Mellinger, discussions of Mellinger is not found to be fruitful. Let's talk about modern terminology. When it comes to conversion, the signs being psychological. And when we talk about functional, we are talking about the abnormal functioning without existence of a functional pathology. However, functional is a theoretical and it's ambiguous. So it doesn't point to the importance of psychosocial factors. So this doesn't require being alone. So medically unexplained means that we say that etiology is unknown. However, we say to the patient that we do not know what the disorder is, therefore we do not know how to treat the patient, how to treat the disease. So you have an unexplained disease also means that I couldn't understand your disease, so I cannot treat your disease. So non-organic is more about what it is not instead of what is. So it's not very satisfying. I'm gonna skip them. The functional wording is a bit confusing and ambiguous. He has a long history and it has different meanings. Charcot used the wording functional for migraine. So Insecurity towards psychological theories is evident. However, neurology and psychology, the conversion and dissociation terms should be protected, as quoted by prominent psychologists a decade ago. Psychiatric classification systems. Let's have a look at the bottom lines. DSM, conversion, hysteric neurosis, conversion disorder. And in 2013, in DSM-5, in light of all these discussions, conversion disorder is used, but functional neurological sign disorder uh, term has been recommended. Well, my intuition is that in light of all the developments in the future publications, functional neurologic sign disorder or something similar to that disorder. So conversion disorder term will not be used, will be replaced with functional neurologic sign disorder. In January version, it was used as dissociative conversion disorder. In ICD-11, in line with Pierre Janet's tradition, they use the word of dissociation. So, dissociative neurologic sign disorder and conversion disorder are used similarly. Functional neurologic sign disorder, the seizures, attacks, loss of strength, abnormal movement, feeling problems, sense problems, a difficulty in swallowing or difficulty in speech, or they are there together in combination. In my talk, in this part of my presentation, the main idea is the positive diagnosis. In the history of hysteria and making a diagnosis, positive diagnosis means that the signs are not habitual, are not weird, but positive clinical diagnosis should be made. That walking, it's not like walking is weird, but positive findings, one or several of positive findings should be there. And the signs within themselves are inconsistent. For instance, going inside a room, going outside the room, while sitting, while lying on the bed, etc., they should be inconsistent. Psychological measures, although they are not reliable, they are deeply related with the feeling of validity. So, in one of the videos, one of the patients who had voice problems was discussing, who was aponic, was discussing his tenant on the phone and for 45 minutes, and then he said that he couldn't speak. Or a patient who has dystonia after signing a paper that he doesn't want to sign. So these findings are there in these patients. Positive neurologic findings, the sign is not consistent with the existing neuroanatomy and physiology, because the concept of leg or arm is, and what is found in the anatomical books are not consistent. Findings are inconsistent, different outside, different in the office. And there are some signs which are specific to hysteria. I'm going to talk about them. One of them is the Hoover finding, a popular American physician. There are two Hoover findings. Our young colleagues know it better. Second one is the obstructive lung disease when the patient takes a breath, the distance between the ribs uh, go inside. The sensitivity is 94, specificity is 99%. This finding, I'm talking about Hoover finding. One-sided hemiplegia is there in the patient.
Sağ tarafında güç kaybı
In the right-hand side, there is a loss of strength, and the patient, the physician puts his hand under the foot and wants the patient to press the leg. Patient cannot press or could not do it by using his strength. The physician, for the second time,
ekstransiyonuna geçirilmesini
wants the patient to extend the hip and to show resistance
bastırmaya çalıştığı
when he
sırada
tries to push down his left leg. The pressure, he feels that the pressure is increasing. That is the Hoover finding.
reaksiyonla ilgili
So
fosfolipidenlerin
these
bozukluğu
conversion signs,
çok iyi
functional
bilinen
neurologic signs,
bilinen bir
this is a very well known finding. The specificity is 99%, sensitivity is 94%. When you find this finding, you do not need to do it when the patient is laying. You can do it while the patient is sitting. You can want the patient to press. The patient cannot press or push down. However, when he puts the leg in extension, when you press it, when the patient presses it, pushes it down, if you find more pressure, abductor finding, the sensitivity and specificity in certain findings is 100%. Instead of pushing down, pressing down, you want the patient to open the legs and show resistance while opening their legs. This is similar to Hoover finding. The weak leg cannot do abduction, and when you want the patient to open the leg, when you want him to open the opposite leg, he shows resistance, and the weak leg strength comes to the normal. So there is a loss of strength when losing the leg. So specificity, so you want the patient to extend the arm and you touch the arm and the patient eases the arm without showing any resistance. So sensitivity is not high, but specificity is very high. So this co-contraction finding, specificity of this finding is 100%. Normally, if we are to extend an arm or just, the biceps is contracted, triceps is released, but co-contraction is their contraction at the same time. When you try to open the wrist of the patient, you see that they cannot move it to both directions because of the flexion of both biceps and triceps. So specificity of this finding is 100%. So it's drift of the arms without pronation. Specificity is 93%. However, the patient, for instance, opens the arm palm upwards close, when you want them to close the eye and move down, if they cannot move it, it's weak, and it should be in the pronation when lifting, when releasing the arm. So if the arm is released like a unliving thing or a lifeless thing, we just look at the signs of the disease. So these are the historically defined signs of neurological function disorders. This is who we're finding in a sitting position. Finger abduction finding. A patient having difficulty in opening the fingers. In the right hand, there is a lack of strength, but left hand is strong. When you want the arm, the finger to resist, the weak one, fingers number 4 and 5 are opening. This is also a positive finding. Walking disorders I'm going to talk about. So until now we talked about the strength findings. The most ancient findings is dragging the feet like a log. So Saint-Pétrière in Charcot's clinic, I'm going to show you the pictures. There are very well defined images in the journal. Uneconomical. It's waste of strength or false taxi. It's like this type of crossing the legs while walking, or an imminent curve of legs. So this is also a positive sign. Over slowness in catatonic patients, as it's sometimes similar to them. Patient cannot begin. They cannot move their feet, and this is also there in Parkinson's disease as well. But after taking the first step, they walk like a Parkinson's disease. However, these patients are moving like they are walking on ice. I'm gonna show you some videos. This is Nouvelle Iconography de Salpêtria. This is a journal inside the hospital. Charcot is an artist, an architect, and Paul Richer is a very famous psychiatrist. And this is a patient with walking disorder. And as you can see, the patient is dragging his leg like a log, a tree log. This is what hesitation, like what hesitation as I have mentioned. The patient is about to collapse, but she's not collapsing, holding the wall. Another positive finding is that the patient is falling towards the physician, not to the ground. However, although she takes steps to the sideways, she's not falling to the sideways, but towards the direction of the physician or to a place where she can lean on. Sit down to the chair, extend your arm. Put your finger to your nose and then to my finger. To your nose, to my finger. It's a clear, there is no clear cerebellar problem. This patient is a young female patient,
Ayağının arkasında çünkü
dragging her feet
bize
behind
zaman
her,
zaman çözümlere
and
başvuruyoruz.
there are problems in the knee.
Çok zor
Knees are
ayakta olduğu
disintegrated.
sürece
She's having difficulty in walking. She's walking like she's walking on ice and asks for help from her father. She has not fallen down, as you can see,
açlık havasını düşürdü.
but she's gonna
Bu hastanın
make her father fall down.
sabah
This
bir
patient,
saatlik bir kurs var.
there is a 3-hour course tomorrow morning with our colleagues from Hacettepe Department of Neurology and Psychiatry. In
Bu
this course,
hastalara yaptığımız
we're gonna show a multidisciplinary treatment that we apply to these patients. The patient, after her hospitalization, this is a 2-year story, by the way.
ne teşhisleri konduğunu size
Previously,
söyleyebilirim.
she was diagnosed with
MS teşhisi kondu.
MS, multiple sclerosis, Wilson's disease,
Pregabalin,
pregabalin, mysoline, many different agents were administered, and these symptoms have resulted in severe disability. And this is how she looks after treatment. The same patient, by the way, this is a distorted view. She looks like she's a little bit chubby, but the patient is the same. As you can see, her walking has been totally corrected, improved. This is a very typical position, the patient with disintegration in the knees, weakening of the knees. Well, we just blurred her face because we haven't taken her consent, but the others, we have taken their consent. This is a very eminent case with weakening in the knees and using arms more. She's hesitant. This patient is suffering from MS. Well, having an MS does not mean that she doesn't have any functional neurologic finding disorder. Benign MS is there, but this symptomatology is not related to her MS. Abnormal walking disorders like dragging the feet, dragging gait, specificity is 100%. This is an historic finding symptom. It's there in the textbooks for 100 years, but well, chair test, I haven't provided with any videos. When you put the patient to a wheelchair or with the chair with wheels, they can move freely, and the wheelchair's specificity is 100%. Functional tremor is one of the most frequent disorders. They have an imminent onset, and with the destruction, it reduces. So I'd like to focus on an examination finding called entrainment. Entrainment does not mean training. Instead, it is like dragging of a log against flood. So it is one of the most useful findings for differential diagnosis. So this is a patient diagnosed with MS. She has Wilson's disease, by the way. Extend it towards me and hold the cup in your opposite hand. So when you organic tremors reduce when you hold something, but with functional tremor increases by holding something. Just move it towards your mouth. Please go back to the chair again. We ask the patient to draw a spiral. This is, she's an artist, by the way, and due to tremor, she could not draw a spiral. And when we asked her to lift her leg, you can see she's having difficulty. What attracted our attention is that variability while she's sitting, there was no tremor. When we asked, do you have tremor in the leg? Her left leg started tremoring, shaking with different frequencies. Then when she tried to lift the left leg, you can see that her tremor in the right leg stops. This is the video she sent to us in our training. Hello, this is Fatma Nur. My treatment and diagnosis were made last year in Hacettepe University. Before the diagnosis and treatment, I could not walk, I could not use my hand, and it is a huge loss for an artist like me. And now I have returned to my academic life, and I'd like to show you my current status. I can walk normally as I did. I can speak, I can do sports. I have returned to my normal life. There is no spasm or no problem whatsoever. Or when there's a problem, I mean, with physiotherapy, I can correct them. And I wish you all the best in your efforts. The patient learned triggering factors. You can see her healing improvement. Sometimes there is a slight increase in the findings, and in those instances, she has been using what she has learned. Um, Entrainment in the left hand, there is a functional tremor. The patient wants the patient to open and close the hand once in every 3 seconds. I mean, 3 times in every second. So the tremor's frequency is in line with the other hand. So this is a typical finding of entrainment, and this is specific to functional neurological disorders.
Bizim çocuk
Here we see a little child from our pediatric neurology department. You can see the tremors continue as he walks. So you would expect once his attention slips, the tremors would subside, but it does not happen. It's quite typical, as you see. The tremors with wide amplitudes happen when the physician who is carrying out the examination asks him to open and close his palms. The tremor stops. And here you see the whack-a-mole game, which is well liked by children. You would find that in arcades, and once you hit one of the moles, whack-a-mole on the head, one of them, the other jumps up. And this is quite a description for functional tremors, I would say. If a functional tremor disease who has a tremor in the hand, if you hold their hand or arm, the other hand or the other arm would start moving. So it is a good analogy. I know it's quite late and you are tired. I'll just show you a few dystonia patients or symptoms, and I will leave you with that. Functional dystonia has been known for such a long time, and these are fixed dystonia, cases of dystonia. Of course, for distinctive diagnosis, we cannot do that as a neurologist does, as much as they do. But fixed dystonia needs to be fixed, as I've said. So if there's a dystonia at your hand, it needs to stay like that, as I show you. So it stays as is without opening or closing. Or if you have a feet dystonia, it stands like that, turned inwards. And secondly, it needs to be first it needs to fix. Secondly, it needs to cause pain. And if there is a spasm on the lower jaw, it needs to be flexed downwards. Contraction, as you see, if it is facial. Now you see a patient of ours who has been with us for 3 to 4 years. The patient says, I'm even worse. So the foot hurts a lot and is turned inwards. And this is a patient who has shown these symptoms for 4 years. There were Botox injections that were administered, and the situation did not improve, and there was quite a lot of pain. So you can consider that functional dystonia may not or cannot be fixed in a sense with Botox injections. So even though you may paralyze the nervous fibers with Botox, still the symptoms continue. And with if you, for instance, administer a Botox with a functional dystonia patient, they can come to you saying that I'm all right the next day, but in 3 to 4 days, the symptoms return. And in organic dystonia, the symptoms start to clear off within 3 to 5 days. And again, from Charcot's clinic, another case of hysteric blepharospasm. So it looks like ptosis, but it is not that. So the muscle orbicularis oculum closes up completely. In organic paralysis, if the eyelid is drooped down, the patient would try and open his or her eye by moving their or dragging their eyebrow upwards. But here we see the other eyebrow, the normal eye's eyebrow is extended upwards, and the other side is the eye is closed and the orbicular, or the muscle is not active. Again, you see a hemifacial spasm, and I believe this is a an engraving or a gargoyle from a church in France. So you see the face flexes towards the portion of the face where the tongue is flexed towards. And Mesut would know about that. This is one of our older patients. She was asked, so this is a patient with a pacer. So she was installed a pacer, and you see the laterocollis, a very severe turning of the neck, and in functional cases, you would see the shoulder lifted up towards the neck, and the other shoulder droops down. It is quite marked and typical, as you see here. Here you see another patient with hemifacial spasm, quite classical textbook case. The sides of the mouth are fixed. They do not move towards the side. So the dystonic movement, the spasm, does not move about and is fixed on one side. So maybe this is something that you can keep yourselves with when it comes to this discussion on dystonia. So there's pain and there's fixation. And just a few things I would like to talk about convergence spasm, which is a very well-known functional problem. Let's say the patient is instructed to look at your finger as much as he or she can for at a distance of 10 centimeters. And the same is done to the other side. And when you bring it towards the middle of the face, you would see a picture that looks like the abducens paralysis. And the one eye can be turned, but the other cannot be. And you see meiosis as well. This is another classical textbook definition, conversional or functional symptom. And a few more functional examples, neoclonus, for instance. These three are videos of the same woman, same female patient. The person says, the husband says, it has been almost 5 minutes that she has been doing this, moving the head, and the frequency changes in time as well. They don't, as you can see, there's nothing wrong with the extremities, and you would see these in the distal parts, the myoclonies, myoclonic jumps. We would see it in the extremities, but here we see it in the body and the head. So the head is dropped down. And the same patient, while she's laying down, as you see, the pattern has changed. These jolts, the pattern of the jolts or jerks have changed. Again, different pattern here. In time, you see the pattern differentiates or differs. And again, there are semiological differences too. And almost 60 years ago, there was one thing that was brought about as a description by two electrophysiologists, German electrophysiologists, which is called the Bereitschaft potential. So you see, it means an upwards potential, and before willed movement, we see that. And Al-Libet finds that this is a evidence that human beings do not have free will, and it was later understood by psychologists and philosophers that this is not a good description. And this Bereitschaftspotential is seen in our patients. So these are voluntary, these are movements that make use of the voluntary neural pathways. And let me end with these two slides, if you'll allow me, distinguished chairs. Now, we are talking about, once again, functional neural disorders and neurological disorders displayed together. The gentleman has Parkinson's disease, and he says, I found that I was unable to continue with my normal life, and I can't talk clearly. The number of words that I am unable to pronounce has increased. So he is having a hard time talking. He says that he cannot remember some words as well. So again, there is no label indifference as mentioned in the textbooks. He's quite anxious and worried, as you see, and this is following the treatment. He says, "Professors, hello. For the last month, I have been having a good day followed by a bad day, and I called you to come visit you in Ankara. I'm doing much better now, but tomorrow, most likely, I'm going to have a bad day, if I expect it, maybe." So, like, there's this fluctuation. He says, I'm not sure what's going to happen, but if I think I'm going to do bad the next day, that happens. So it's like expectations have an impact on the picture of the patient. Also, there are positive sensory findings, which range from sensory disorders in the middle line, disrupted vibration, and loss of sense, which do not follow the anatomic distribution. So looking at that, looking at the neurological textbooks, you would find that the loss of sense does not follow that. So it's a positive sensory finding. Concerning this, there are many important, interesting physical findings. So when you ask or instruct the patient to mimic a paralysis on one side of the body, these are the answers that the patient provides. So in experimental malingering, you would see this clinical picture as well. So it is almost very much like a conversion disorder. So I believe I can end with these words. John Stone, a Scotsman from Edinburgh, a neurologist, provided great contributions to the re-examination or re-advertisement, if you would, of these positive findings, because these have been known for at least 100 years prior. So, in Stone Encephaly, in an editorial article, he writes that I thought that positive findings could be utilized. And when I started using these, many professors of mine came to me and asked me whether it was a good idea or not. And what they clearly tried to say, or implicitly, what they tried to say was that patients would understand the gimmick, and then the tests would not be useful. But of course, in time, it was found that Stone was thinking right. And we are using these positive symptoms as the first step in our treatment, in our path of treatment. So if a functional neurological disorder diagnosis is given, after that is done, the patient gets into contact with a psychiatrist, and after a psychiatric evaluation, the positive findings are focused on, and the patient is it is explained to the patient that since we are unable to come up with any other diagnosis, this is the diagnosis that is being given to them. And whichever of the three previous discussed symptoms are found, these are the reasons that a functional diagnosis is given. And this is, as I've said, most of the time the first step. And with this first step, psychotherapy, occupational therapy, physiotherapy for the patient progresses. And Stone has a website which is called neurosymptoms.org, which is available in many different languages. And the Turkish version is almost ready. There was this patient, if you remember, this young female patient who gave us her name saying that I am much better now, I have been treated. And the video that you saw was sent over to this website as well. So under the patient experiences, you can see an article written by her as well. And from 2019 onwards, neurologists, psychiatrists, and patients groups have established the Functional Neurological Disorders Society, which is quite active and has many members from many countries, ranging from scientists to patient groups being represented here. And they help in bringing awareness about these disorders. So as you can see, psychiatry and neurology, after a very long time, has joined their forces and knowledge bases. So these chronic relapses and disabilities that are caused are now being addressed to cause improvements. So when it comes to positive neurological diagnosis, since it is done with bedside tests, it can be not for sure and is open for mistakes. So we need rule-in diagnoses instead of rule-out diagnoses. Indeed, we have laboratory symptoms that are defined for functional tremor, but not for episodes and loss of power. Maybe machine learning or other laboratory facilities will be able to provide us with that. And this is a very recent machine learning based connectivity study carried out with 86 patients, and 70% thereof were found to be correctly made distinct from healthy control groups. So we need new laboratory techniques that allow us to do that. Thank you so much for your patience and your attention.